Dear friends, in our previous episode, we discussed some of the key philosophical ideas and cultural changes that led to the development of gender theory and subsequently gender-affirming treatment. Gender-affirming treatment basically refers to therapy that affirms individuals in their gender dysphoria. This could consist of any single or combination of a number of social, psychological, behavioural, medical, or even surgical interventions, in the hope that this would help the individuals feel better about themselves and relieve their psychological distress arising from gender dysphoria. We concluded that episode by noting that some of the most liberal countries which had initially embraced this idea and promoted gender-affirming treatment and transition for the young, such as those in Scandinavia and other parts of Europe, have now gone back on their policies and put a hold on this practice. In this episode, we will discuss what contributed to their U-turn. Over the past few years, concerns have arisen from studies that do not seem to support such gender-affirming treatment for the young. As a result, countries such as Finland, Sweden, and Denmark have reversed their policies and no longer prescribe puberty blockers, hormones, or surgery. Instead, they encourage therapeutic counseling and support as essential aspects of holistic care. The rationale that supported this rather radical change in approach was very well documented by a review that was commissioned by NHS England. Its objective? To make recommendations on how to improve gender identity services based on best available evidence and ensure that children and young people who are questioning their gender identity or experiencing gender dysphoria receive a high standard of care that meets their needs, is safe, holistic, and effective. This report, 388 pages long, was submitted to NHS England in April 2024. It was named the Cass Review after Dr. Hilary Cass, who chaired the independent review of gender identity services for children and young people. In presenting its findings, the Cass Review took note of several important points. 1. Without social, medical, or surgical interventions, gender dysphoria naturally resolves in a vast majority of young individuals. According to the American College of Pediatricians, this figure is between 80 to 95%. 2. Systematic evidence reviews demonstrated the poor quality of published studies that were used to support the use of puberty blockers and cross-sex hormones. Results from an NHS early intervention study in the use of puberty blockers showed there was a lack of any positive measurable outcomes. There was no evidence that puberty blockers improve body image or dysphoria, and very limited evidence for positive mental health outcomes. 3. The review recommended that young people referred to gender services must receive a holistic assessment of their needs. This would include screening for neurodevelopmental conditions, including autism spectrum disorder, and a mental health assessment. Why? Because studies indicate that up to 42% of these individuals meet criteria for autism, and up to 62% had one or more diagnoses of a psychiatric disorder, such as anxiety, depression, obsessive-compulsive disorder, and eating disorders, among others. A Finnish study found that more than 3/4 of the referred adolescent population needed specialist child and adolescent psychiatric support due to problems other than gender dysphoria, many of which were severe, were present even before the onset of gender dysphoria, and were not considered to be a result of the gender dysphoria. It seems quite apparent then that gender dysphoria is often not the main cause or the main source of the problem, but a symptom of something else that goes much deeper. Adverse childhood experiences, or ACE, have also been found to be strong predisposing factors for gender dysphoria. 4. A further concern is the complications of treatment with puberty blockers and cross-sex hormones such as weakening of the bone structure, resulting in osteoporosis, as well as adverse effects on the cardiovascular system in the longer term, such as stroke and coronary vascular disease. What happens when we expose XX body somatic cells to high doses of hormones meant for XY body cells, and vice versa? No one knows for sure yet. Another worry concerns their neurological development. It is thought that adolescent sex hormone surges may trigger the opening of a critical period for maturation of the parts of the brain concerned with planning, decision-making, and judgment. If this is the case, brain maturation may be temporarily or even permanently disrupted by the use of puberty blockers, which could have a significant impact on the young person's ability to make complex, risk-laden decisions, as well as having possible longer-term neuropsychological consequences. 5. With regards to suicide, it has often been claimed that individuals with gender dysphoria would have a higher risk of committing suicide if they were not allowed to transition. But the CAST review, which extensively reviewed the available data, concluded that the evidence does not at all support this claim that gender-affirming treatment reduces suicide risk. So all these explain why the CAST review recommended a very different approach to healthcare, one that considers the young person holistically and not solely in terms of their gender-related distress, in contrast to the gender-affirming model. Allow me to summarize what we have discussed so far. 1. Studies that appear to promote the use and benefits of so-called gender-affirming care have been found to be of poor quality. 2. A significant proportion of the population with gender dysphoria have associated neuropsychiatric conditions such as autism and mental health issues such as anxiety, depression, obsessive-compulsive disorder, eating disorders, among others. 3. There are health concerns related to the medical treatment offered as part of gender-affirming care. 4. The claim that gender-affirming treatment reduces suicide risk is not supported by the evidence. 5. Gender dysphoria resolves spontaneously in the vast majority of cases if individuals are simply allowed to follow their natural development through puberty to adulthood. Okay, so we have talked about what gender theory is, how it came about, and shared some data about transitioning among youth. It is now time to turn our attention to the most important subject of this topic: the person who experiences gender dysphoria. We can see from the data presented that many individuals with gender dysphoria are challenged with various neuropsychiatric disorders such as autism, anxiety, depression, obsessive-compulsive disorder, eating disorders, among others. Indeed, there are many factors that can be associated with the development of gender dysphoria. Every individual has a different story to share with us. If only we would stop and listen to him or her as Jesus would. Which is why the church is so adamant on the need to differentiate between the concept of gender theory or gender ideology and the persons who experience gender dysphoria. Individuals who deserve our love, empathy, and understanding, no less. How do you do this? How can we journey with them in truth and in love, especially if they are our children, our sibling, our friend? We shall look into that in our next episode, where we interview a psychologist, counselor, who will share with us some tips on how we can go about doing this. Before we end, we invite you to click a like to this video, share it with others you think will benefit from it, and help us spread the good news of Catholic parenting. God bless you and your family always. Bye for now.